Hello and welcome to Everyday Oral Surgery. This is your host, Dr. Grant Stucki. I am an oral and maxillofacial surgeon practicing in Denver, Colorado. The goal of this podcast is to connect, learn, and inspire. In this podcast, you'll be hearing from OMS surgeons all over the globe discussing ways to improve the practice of oral and maxillofacial surgery. Most information shared in this podcast will be based on personal experience and opinions, so please supplement what you learn here with approved research studies. Without further ado, please enjoy today's episode. All right, everyone, welcome back to another episode. Today I'm with Dr. Jake Stucki. Jake, thanks for joining us on the podcast.
Absolutely. I'm excited to be here.
Excellent. We thought it'd be a good idea to do a few anesthesia podcasts where we kind of focus on some of the more common drugs that we're using and profile those drugs, more of a review. So certainly nothing groundbreaking or earth-shattering here, kind of a review for a lot of people, but I think always good to brush up and make sure that you're aware of all of the aspects, the ins and outs of each of the drugs that we're using. So we'll start with the most common drug we use. Probably, I would think, would be the most common drug amongst all oral surgeon usages would be Midazolam. Where would you start us off, Jake, on the topic of Midazolam?
Yeah, so I think let's just go over some of the basics of midazolam. What is it? How does it work? I'm sure most people know a little bit about this, but it's a water soluble. It's a benzodiazepine. So as we know, there's barbiturates and benzodiazepines. They both have very similar effects. Benzodiazepines are, essentially more modern, a little less respiratory depression, a little newer, and better safety profile. So some of the kind of high yield things I think when I think midazolam is it's a very rapid onset benzodiazepine. So after you push it, you're gonna see initiation of onset within a minute or two, and then sedation will kind of peak between somewhere between 3 and 5 minutes. It also can be administered intramuscularly, but it does take a bit longer to peak there. That'd be like a 15-minute time. And then with it being a rapid onset, one of the that's a huge benefit for us doing IV sedation, total IV sedation, anesthesia in our offices, but it also has a short duration, right? So the IV effects typically last between 20 and 30 minutes, with the elimination half-life being around 3 hours. And that can be anywhere from like an hour and a half to like just over 6 hours. But what's so nice about that is we're doing short, quick procedures. We can have a short, quick acting, rapid onset, and then short duration medication, which is, great on both sides and it's very safe. Yep. And then, so those are kind of the things that I think about in terms of timing. And then in terms of its effects, we know that it produces anxiolysis, really relaxes people. People are super nervous to see us oral surgeons. Their heart rate's up, their blood pressure's up, they're super stressed just because they're thinking about the procedure and no one wants to go to the dentist. We all know, everyone tells us that. So it can help, first off, eliminate that, starts beginning the sedation. And then one of the best things about midazolam is it produces that interrograde amnesia. So I in preparation for this was looking at some articles and found an article about endoscopy where it's also commonly used, and they said up to about 80% of patients had absolutely no recall of the procedure just from the midazolam alone. So that's, a very, very beneficial feature in terms of these quick, short procedures. But one of the things that is mentioned is that it does not produce any analgesia. So, even though it's going to help with their anxiety and their consciousness level, it's not going to reduce pain whatsoever. And so we have to take that into consideration, when we're doing our procedures.
Awesome. So benefits are rapid onset, short duration, produces anxiolysis and amnesia, but no analgesia. So we're going to be using another drug for the analgesia type stuff. Mechanism of action, I can talk a little bit about that. It's a positive allosteric modulator of the GABA A receptor. So it doesn't activate the receptor directly. Instead, it enhances kind of the endogenous GABA, increasing chloride influx into neurons and hyperpolarizing them, which reduces neuronal excitability. And that results in anxiolysis, sedation, amnesia, anticonvulsant activity, and then skeletal muscle relaxation. So all things we're looking for that are helpful I mean, helpful, especially anticonvulsant and kind of pairing it. We'll talk later and do another episode with ketamine, but where ketamine may decrease the threshold for, a seizure, this would increase it. So they kind of balance each other out, which is good. Any comments on the mechanism of action?
Not in particular. A couple different sedatives work on the GABA receptor. Alcohol. I think even propofol is thought to work there. So not a medication you really want to, mix with anything else like that. So our patients should be obviously sober, not on any other influenced by any other medications. And then the anticonvulsant activity just reminds me of there are other medications. I know Brevitol used to be very common that lowered the threshold as well, which I don't think that's being used quite as much anymore. And then other things that I would think about. So the pharmacokinetics is more of a I know it's like a lecture kind of thing that we don't always think too much about, but in addition to the onset and the peak and the duration, I think it's just important to remember how it's metabolized, which is it's via the CYP3A4 enzyme. So about 70% of the metabolites turn into 1-hydroxymidazolam, and then a very small percentage of them are other compounds for hydroxymidazolam and other a little bit of the drug is excreted directly in the urine. But it's important that it's mainly metabolized in the liver. So people with hepatic impairment that could last quite a bit longer. And then the active metabolites are still pharmacologically active. So in even healthy older adults, the it's found that midazolam's half-life can be quite a bit longer, even at up to twice as long. And it can take them just a lot longer to get rid of it. People who have cirrhosis, it could also take, twice, two, three times as long. And these effects can linger for a very, very long time. And then people who have any sort of renal impairment, because the glucuronidated metabolite is excreted in the urine, that could also build up, and that's active. So these are just things to think about. People with liver or renal impairment, we have to adjust our dosing because of the duration of sedation can definitely be increased.
Okay, nice. So just in review, the onset's 1 to 2 minutes, and the peak is about at the 3 to 5 minute mark. And then just being aware of some of the things that can cause it to last longer or have a delayed effect, especially if you're having hepatic issues with metabolism there. All right, indications. So we use this. Number one is for anxious patients, which is pretty much all of our patients. Needle phobic patients, it's great for dental alveolar routine third extractions are great for implant surgery, multiple extractions. Um, can be used in multiple forms. Typically we get the IV first and then give it to one. Usually the first drug I would think most push through the IV. With that said, you can give this orally, and then yeah, I mean, a question is, I know for you, sh should or does every patient you treat get Versed, or when would you not maybe use Versed?
Yeah, that's a great question. I would say the vast majority of my patients give Versed, but there are a small subset of patients I don't give it to. Based on the American Geriatric Society Beers criteria, if you guys haven't seen it, just look it up. You can just Google that and type PDF. There's a list of medications that the Geriatric Society has come up with as potentially risky to give to elderly patients or frail patients, just because of their side effect profile. And so if I have patients who are over 70 years old, or maybe they're over 60 with like a lot of comorbidities, not a ton of other risky medications, opioids, and just frail, then I try to avoid Versed, or at least limit the dose significantly. Definitely with patients who have some sort of like mental impairment, some sort of spacing right now. What's it called? Oh, definitely with patients who have like Alzheimer's or other sort of memory conditions,
Hmm.
or maybe disorientation, those kind of patients in the elderly, I would definitely not give Versed, and I would get a med consult, prior to sedating them. In those patients, I've found some success in using like a low dose fentanyl with like just a little bit of propofol to go for more of a moderate sedation. So that's at least my take. And then, you did mention administering Versed in other ways other than IVs. I think We could do a separate podcast on this, but when I've done like a dart for induction of patients who can't tolerate an IV, we'll put in Versed into our dart,
Mm,
mixed with ketamine and glycopyrrolate, and then the syrup has also been super helpful for me when sedating like really young children for very very
yeah,
short procedures. If they can't tolerate getting the IV.
yeah. Same. When you say dart, you mean an IM injection, usually a deltoid. Yeah, generally for kids, we're doing that mixing Versed with ketamine, and those work really well. So typical adult OMS dosing, the initial incremental IV doses is generally, I would say most would be giving zero point 0.5 to 2 milligrams, kind of as a IV bump or in I guess you could say a bolus. And then additional doses kind of titrated. Usually, I would think most would give, 1 to 3 maybe milligrams, see how the patient's doing, give it a couple minutes, and then another dose if needed. Many adult office cases total, I would think a lot of the literature says 2 to 5, but I think a lot are, and at least in world maxillofacial surgery, are using 5 plus and are noticing good results. I do want to emphasize that you need to titrate it for sure and just kind of um, give it slowly, watch what happens, that type of a thing, and be aware of some of the reactions. People can get into stage two and other stages when you're combining these medications with others. So I think be careful with it. Any thoughts that you have on dosing?
Yeah, at least in my experience and for what I've seen, a lot of providers will give 2.5 milligrams to 5 milligrams, somewhere in that range, and then give either fentanyl, ketamine, maybe Precedex, propofol, use a small dose of each of these medications to kind of maximize their sedative and beneficial properties and try to minimize some side effects. And
Yeah.
then once those medications have taken effect, evaluate the patient's state of consciousness, their depth of sedation, and then administer more sedation. So, I was looking into different articles and published accounts of people receiving, higher doses of these medications just because I was curious. And I found a couple articles mentioning patients getting up to 15 milligrams of Versed. That is would be a very substantial dose. But there are multiple accounts of people getting that much safely. And then I think it's just like you mentioned, it's important to be aware that it has a synergistic effect with other sedatives, with fentanyl and propofol. So just to
Yeah.
take it slow, to administer it, in smaller increments, and then give it some time to work and reevaluate the patient's depth of sedation. From my experience, I've seen a lot of, times where patients might be in a stage two situation. Maybe they're coughing, maybe they're kind of easily agitated and they're not truly in a deep sedation. And, you really have two options, which is if you're going to sedate them more and get them into that deeper state or wake them up. And so, like, I think it's important to use these medications on patients who are, you feel comfortable getting to a deep sedation because they've got, their ASA 1 and 2 with a very easy to manage airway, in the case of an emergency, and then, try to get them into that safe plane of deep sedation.
Yeah. Yeah. What you're describing is similar to my anesthesia technique with that. Usually an initial dose, well, at least within the first few minutes of 2.5 to 5 over a few minutes, combining that with propofol. In general, I think a lot of surgeons will take out, for example, we're talking about third molars 1 and 32, let's say, and then the patient starts waking up a little bit, moving, kind of showing signs that they're metabolizing pretty quickly through the medication. And oftentimes I would give another um, bump of Versed and propofol. I usually do those two mixed together. So maybe another 2 milligrams of midazolam with 20, 20 to 30 propofol. I know some who just do another bump of Versed and fentanyl, or another friend of mine routinely just does Versed and ketamine as a second bump when he's already given those to start with induction. So it's a very versatile drug that I think pairs well with fentanyl, propofol, and ketamine, and Precedex. You'd probably throw that on there as well. So really, lot of good complementary effects there.
And to add to that, I think one thing to consider is just the remaining duration of your planned procedure, and how the patient's tolerating it. So
Yeah.
if you're halfway through a procedure that's taking, maybe it's going to be a 20-minute procedure, you're 10 minutes in and the patient's, basically passing through stage 2, waking up at this point. If you're going to be using strictly only propofol, likely you would need to bolus them, maybe a couple times for the remainder of that procedure, maybe twice, 2 or 3 times. But if you were to
Hmm.
give something like Versed, which has just a little bit longer effect than something like propofol, then it could last for the duration of that procedure. But I think just like thinking about those things can help trying to avoid having to give many bumps throughout the procedure unless you're using a pump.
Right. Yeah. So desired effects, we're looking for reduced anxiety, better patient cooperation, excellent anterograde amnesia, reduced catecholamine surge, and then just an easier, smoother IV induction when you're combining it so that you're not having to give a lot of propofol, a lot of fentanyl. You can kind of give all these medications in smaller doses and they just work synergistically. Undesired effects would be potential respiratory depression, although I don't really see that with just midazolam alone, but I can start to see that when you're using it with fentanyl or propofol. Airway obstruction potentially again, that's more with a combo of propofol, I would say. And, this can go along with hypoxia. I think probably the more common undesired effect when people think about midazolam is potential over sedation. Um, and just giving too much, and then potentially that the paradoxical agitation. So getting in this weird stage 2, maybe rough wake ups, people crying, things like that, getting agitated and anxious. But like you talked about, is if you're comfortable with complementary medications you're using, I usually err on the side of going deeper and getting them in a more deeper zone of anesthesia as opposed to the other option, which is waking them up more. The beauty of midazolam of Versed is that it has a great um, reversal, which is flumazenil. I think a year or two ago we profiled that one, but I mean it's just so awesome that it has a pure reversal and you can use it. It's easy to use. It's fairly inexpensive and works very quickly and well. Any thoughts or comments you have on the desired and undesired effects of midazolam?
Yeah. I think one thing that's pretty common for people to see during initial induction of using our typical protocol is a slight period of that respiratory depression or just apnea, right?
Hmm.
But I think an important thing to consider is um, at the very beginning of the procedure for a standard oral maxillofacial surgery procedure, where the patient's the deepest, maybe they're apneic for 30 seconds. That's when we're administering all of our local anesthetic, which is, theoretically the most painful part of the procedure. And
Hmm.
so you're providing a pretty strong stimulation to the patient, which can kind of counteract some of that respiratory depression and cause them to, you know, take breaths essentially. So that's one
Yeah.
thing that I think we're timing the medication with certain parts of the surgery to minimize those undesired effects and kind of basically balance them out. We want the patient to be a little bit deeper during those periods because it is very uncomfortable to have all four quadrants numbed, back to back palatal blocks, IAN, and all that kind of stuff.
Yeah.
So that's one thing that I feel like kind of is helpful with our procedures just to get through that initial area. And then I found it very, very unusual or almost never happens to get a patient who has respiratory depression just randomly throughout the procedure, with small like repeated doses. Typically, if they're having some sort of, respiratory incident, it's apnea from the initial bolus, the induction, or simply just obstruction later throughout the procedure, just related to poor airway management. And so that could be easily corrected with like a jaw thrust, suction, patient positioning.
Yeah, exactly. Yeah, I would say the same. Just make sure that you recognize signs like what you're saying of apnea, hypotension, airway obstruction. Um, you making sure you got your supplemental oxygen, you have someone who's giving a good jaw thrust. Sometimes I would say it's mostly definitely with the propofol usage that you're gonna occasionally see like full apnea where you'd have to get the mask out and do positive pressure ventilation. And then I've mentioned this before, but just I just still think it's so important to have flumazenol and use it fairly commonly so you and your staff know how to use it, know the dosages. Typically, flumazenol is given at I would say zero point 0.2 to zero point 0.4 milligrams of an initial dose. Could be given at higher doses, but generally I would do zero point 0.3 milligrams, and you could almost count to 30, and all of a sudden they're opening their eyes, they're with it, they're coming to if there was some degree of oversedation. But that's just a common thing when we've reviewed closed claim cases. A common thing that is usually missing in the case is the lack of giving the reversal agent when there was one, either that and or naloxone. So just being very familiar with those, knowing how to use them, and make sure staff's familiar with it. What any
I've
Yeah,
I've done just exactly what you said, because of having spent time with you, and now my staff, and we've had some assistants kind of crossover between the two of us, but my assistants, they don't hesitate to ask or to say, hey, would this be a patient who could use flumazenol, or what about this, what about that? And during a case, if I think it's helpful to have your team familiar with it, so that way, if you're thinking about 10 different things, you at least have your team who also can bring that up and remind you, in the case of an emergency. Yeah, so I just wanted to provide a second to that. Definitely making sure, and I think it's helpful. We have a emergency medication kit that we always have in the room. We go over a quick checklist before we start, including, do we have our bag? Do we have our airway equipment? If these functioning drugs are here, and we have our emergency medicine. And just popping that thing open every once in a while just to grab the flumazenol, make sure you're comfortable, know where all your meds are, used to drawing things up. I think it's just keeps you fresh.
for sure. The other things I would just want to recognize, which are rare, but we did have Dr. Funderburk on the podcast, and he talked about a patient who had a true allergy to flumaz or to midazolam, and kind of an anaphylactic type reaction, and needed a lot of airway assistance. I mean, ended up being okay, but was potentially scary. So that's possible, although very rare. But being aware that can happen and being able to treat those types of reactions are super important. Using epi. Any other thoughts on that one?
Yeah, just the underlying idea of using your monitors. You have your 3 lead EKG with the heart rate. You got your pulse oximeter, your capnography, blood pressure, and so these adverse effects. If you can do early diagnosis, notice when people aren't breathing, adjust their airway, provide positive pressure ventilation if needed, place a nasopharyngeal airway, if you're having any trouble. If you notice anything about maybe they're becoming a little hypotensive, a little tachycardic, and you start, just paying attention to the vitals and how that can be influenced by these medications we'll be discussing over the next couple episodes, and just intervene. I think that makes a huge difference. One of the main things I'll notice is just maybe your monitor stops working for whatever reason. Maybe the capnography nasal cannula is clogged, or didn't get screwed in all the way, or whatever it is. Just not ignoring those things, so that way you can know how to use your equipment, and you can trust it fully that it's working.
For sure. On that note, you earlier we were talking about just when you wouldn't give midazolam. I recently had a
Hmm.
patient who was like, I would say mid 40s, female, who said that she'd had a surgery, gosh, 2 or 3 years ago. I can't remember what it was for. I feel like it was for some knee or hip replacement or something, and had Versed, and then she claimed that she had lots of cognitive impairment afterward, had reduced kind of mental sharpness, couldn't remember things. Like her example was she was staring at her garage door and couldn't like was trying to articulate what it was. She was trying to explain it to someone, but she couldn't say that that is my garage door. Like she kind of had forgotten the word for it. And so she was one who said, "Oh, hey, I had this experience specifically with Versed, and I don't want that at all because I'm very worried about having cognitive impairment and memory loss and all these things happening. So I think there is a subset of patients who are more prone to those things. And I think taking a good and thorough history, making sure you ask, have you had surgeries before? What was the effects of anesthesia? Because she offered that up readily, but some patients might not, and you may kind of be giving them something that is causing this kind of could be potentially life altering experience, at least for a few months afterward. Any thoughts on that one?
Yeah, I think it just goes to show the importance of your, pre-op workup, right? Having a thorough health history and then going over it with your patients. I always ask my patients about allergies, all the different organ systems, all the different medications they could be on, and then also probing, blood thinners, bisphosphonates, all sorts of any medications that could have effects. And have you had any previous anesthetics in the past? Any complications, family history, those kind of things to bring up issues like that. Because if they don't mention something like that because you didn't ask or they didn't think to, you could, potentially have an issue that was avoidable. So I think it just goes to speak for a thorough workup, making sure you provide an ASA classification for your patients, and obtain med consults when you need to.
Yep. Awesome. Well, thank you for doing this quick review of midazolam, and hopefully this has been a helpful brush up for our listeners. We'll plan on talking a little bit about propofol next time, but appreciate your time.
Awesome. Thanks, Grant.
Thank you. Talk to you later.
Yeah.
Thank you so much for listening to this episode of Everyday Oral Surgery. For more information on these podcasts, please visit everydayoralsurgery.com. I love feedback and would be very grateful if you would reach out to me via my email, grantstucki@gmail.com, and let me know what you thought of this episode. Or you can text me at 720-441-6059. Additionally, if you have any topics you'd like to hear about, or if you would like to be a guest on the podcast, please email or text me. I found many of my interviewees through people who have been contacting me and I've been listening, and I've gotten so many great ideas for more podcasts, and that's what helps keep the podcast rolling. So I really appreciate you making that extra effort and helping me out with feedback and knowing what to do next on the podcast. Thank you so much.